recording. Okay, good evening, boys, and I am Dr. R. Naveen Reddy, and today's topic is sequelae of missing teeth on oral anatomy and dentition. Now, what are the intended learning outcomes? At the end of the lecture, what are you going to learn? They are like enumerate the reasons for tooth loss, describe the factors influencing the tooth loss, explain the consequences of tooth loss, and you will be in a position to enumerate the effects of tooth loss. And finally, you can analyze the 6 phases of partial denture service. So these are the intended learning outcomes of your lecture. Now, the loss of teeth causes a number of concerns related to loss of masticatory function, aesthetic deficiencies, and the effects of increased demand on the residual dentition. So if you observe carefully, so we have basically 3 things to concentrate on. The first thing is your masticatory function, right? And the second thing is your aesthetics. First is your mastication, the second one is your aesthetics, and the third one is your heavy load on the residual ridge. Because there are no teeth, the loads are being transferred to the residual alveolar ridge. So both objective and subjective factors may affect the patient's desire to consider tooth replacement, and the advantages or disadvantages of any intervention must be weighed carefully. So if you are planning for implants, or if you're planning for FPD, or if you're planning for an RPD, or you should observe all the advantages as well as the disadvantages which are there in each treatment. And when you are going to do any prosthodontic treatment, first you need to know that you need to concentrate on the elimination of the first oral disease. When a patient comes to you, you should concentrate on eliminating the oral disease first. Then later on comes your preservation of the health and the relationships of the teeth and the oral musculature. So first is you have to eliminate any oral disease which is there and which is the chief complaint of the patient. And the next one is preservation of what is there in the mouth first. Then only you can start with restoration of oral functions. So rehabilitation starts only after elimination of oral disease, preservation of what is there in the mouth, then only the rehabilitation or restoration of the lost parts will start. So it should be in this order only. You should never start thinking of rehabilitating the patient without preserving what is there in the patient's mouth, right? Now, coming to the reasons for tooth loss. What are the reasons for tooth loss? Tooth loss can happen because of accidental trauma, tooth decay or dental caries, gum disease, certain illnesses, certain chronic medications, smoking, tobacco chewing, excessive alcohol, and drug abuse, eating disorders. All these are reasons for tooth loss. And what are the factors which influence the sequelae of loss of teeth? So there are many factors like your age, the gender. Like in males, the tooth loss is more when compared to females. Smoking is one habit which is more in males when compared to females. Lack of professional maintenance, inadequate oral hygiene. There are many systemic diseases like diabetes mellitus, hypertension, rheumatoid arthritis. And finally, the tooth type. So based on the anteriors and posteriors, which type of teeth are lost first and which type of teeth are lost later. So that is also a factor which influence the sequelae of loss of teeth. Now, coming to the first one, tooth loss and age. Now, there is a study in which they found that the lower 6, 4-6 or 3-6 are at high risk of loss. The tooth loss most of the times happens with the molars, the lower molars, the 6 and the 7s. And later on, the risk is transferred to the upper molars, the maxillary molars, upper 6 and 7. So 1 6, 2 6, 1 7 and 2 7. Then comes your mandibular second premolars. Then later on comes your maxillary central incisors, lateral incisors, maxillary first and second premolars. Now coming to the low risk region, the low risk regions are the upper third and the lower fourth. So what are the upper thirds? The upper thirds are the maxillary canines and the mandibular first premolars. The lower thirds are the mandibular first premolars. And finally, the least risk groups are the lower anteriors, mandibular centrals, mandibular laterals, and the mandibular canines. So most of the times, these are the teeth which stay in the mouth, whereas all the teeth are lost. So this is based on a study which was given by these people here. According to which factor specifically? Yeah, according to which factor specifically? There are many factors. As I told you, I'm going to discuss about it. There are factors like, so most of the times it is the decay. It is because of caries, right? So this is generally because of caries, right? And it can be because of gum disease also. So these observations, if you can see this second line, these observations are likely related to respective caries susceptibilities which have been reported. Okay, so this is all because of the caries, right? And comparison, this study is based on the comparison of caries susceptibility of various morphological types of permanent teeth. So this is the main reason for this type of loss. And if you observe carefully, if you go to the previous slides, so here if you see this slide, most of the cases, the reasons for the tooth loss is most of the times the dental caries. Dental caries is the main causing factor for tooth decay, right? Now we'll go to the next slide. So we finished age, then we will go to the next slide, the dental caries, right? The most common reason is tooth decay or the dental caries. And in a study was performed, and in which they found that total of 1,791 teeth. So what they did, they started collecting the extracted teeth. So when they started collecting these extracted teeth in a total of 1,791 teeth, most of the teeth, that means 708 teeth were because of caries. They were extracted because of caries. So this amounts to 39.5%. So of the total number, of the total 1,791 number, 708 teeth were lost because of caries. So this forms the major cause for the tooth loss, right? And the second reason for the tooth loss is the gum disease or the periodontal disease, or it can be called as gingivitis, which slowly progresses to periodontitis. So they found that in the total of 1,791 teeth, 508 teeth, which amounts to 28.4%. So these teeth were extracted because of periodontal disease. So this is the main these are the two main reasons. One is the decay and the second one is the gum disease. The third factor is smoking. Smoking is also a major cause for tooth loss. Okay, and they found that in a study they found that smoking rates differed greatly in men. So men almost like 53.3%, and women like 15.5%. So the overall prevalence of tooth loss was 31.4%. So how many cigarettes per day, and what is the duration? Let us see this interesting study. So if you see the second point, the number of teeth lost depends on the dental habits and how much a patient smoke. The Academy of General Dentistry found that people who smoke a pack of cigarettes a day, that means a pack is like 10 cigarettes per day, are likely to lose 4 to 5 teeth in a 17-year period. And those who smoke less than a pack a day are at risk for losing 1 to 2 teeth every 10 years. So these are the reasons. These are the reasons behind smoking. And one pack a day is like 10 cigarettes per day is too much. It's too much. And they are susceptible to lose 4 to 5 teeth in a span of 17 years. And those who smoke less than a pack, they are susceptible to lose 1 or 2 teeth every 10 years. And what does this smoking do? Smoking contains chemicals. You know what is nicotine? Nicotine is a major chemical which is present in tobacco, and this is responsible for inhibiting the function of gingival fibroblasts, including proliferation, collagen production, adhesion to root surfaces, and induce cytotoxicity. And apart from tooth loss, smoking also can cause oral cancer. So some guys, if you are smoking, please quit as soon as possible. Next one is the parafunctional habits. Parafunctional habits, like when you see this photograph here, this photograph here is a photograph of bruxism. You know, bruxism is a parafunctional habit where the patient, because of stress or because of any habits, they keep on involuntarily grinding their teeth. So non-functional or parafunctional habits involving repeated or sustained occlusal contacts can be harmful to the teeth or other components of the masticatory system. So the mechanism whereby pressure causes soreness of the supporting tissues is probably related to an interruption or a diminution of blood flow, leads to recession followed by tooth loss. Now in the second photograph here, if you see this photograph here, the boy is having a habit called thumb sucking. So because of thumb sucking, you have these deleterious effects. You end up in seeing an open bite here for this patient, right? So all these problems create further problems like mouth breathing, periodontitis. Then there is tooth loss. Now coming to tooth loss and general health. Now there are many systemic illnesses like diabetes, cardiovascular diseases, hypertension, uh, all these problems or any nutritional deficiencies, all these they can end up in showing some effects on, yeah, diabetes mellitus. DM is diabetes mellitus. So all these problems, they end up in showing on the teeth also. So you will have a lot of problems with systemic illnesses. And most of the times, if you see diabetes, this is the condition of patients in diabetes, uncontrolled diabetes. So here you can see there is a plaque accumulation, calculus formations, gingivitis and periodontitis, and which ends up in tooth loss. And in diabetic patients, there is a condition called xerostomia, which is dry mouth. There, in diabetic patients, the salivary flow is reduced, so they end up in getting a dry mouth, which further enhances microbial colonization, and the patient ends up in having a lot of problems like this. And there is one more study which is relating the tooth loss and psychological conditions. So here any psychological factors like depression, anxiety, stress level. So all these also play a major role in tooth loss. So in patients who are mentally handicapped, or they are in a state of depression or anxiety, Alzheimer's, yes, Alzheimer's also, yes, Alzheimer's also, they will have uh, yeah, it's a psychological condition. Yes, these patients also will have tooth loss. So they said that in these patients the tooth loss is more when compared to normal individuals. And finally, if you see the type of teeth, there are two types of teeth in our mouth. So one is the aesthetic unit. This is called as the aesthetic unit, and you have the occlusal unit, right? Now let us see what are these two units. We have the aesthetic units, which are the anterior teeth, the central, lateral, and canine, and we have the occlusal units, which consists of premolar and molars. So we have 4 premolars and 4 molars on one side. So this is how we have 14 functional units in the mouth on one side of the arch, right? So totally we have 28 teeth. Now, if you observe carefully at these functional units, we have anteriors for biting. For chewing, we have premolars and molars. For speech, most of the times the anteriors, the tongue keeps on moving, it keeps on touching the palate and the lingual aspects of the anterior teeth. So anteriors play a major role in the speech. And for the aesthetics, we have anteriors, premolars, and molars, because sometimes it depends on their smile. Some patients, when they smile, only the anterior teeth are visible, but some patients, for some patients, it is also the premolars. And if you see some patients, their smile is so big that even the second molars are visible. So if the lip line is so big, the canine line, the lip line is so huge, so even the second molars are also visible. And the stability of TMJ, since we have teeth, the teeth act as stress breakers for the TMJ. So the teeth will not allow the mouth to overclose. So that's how they protect the TMJ. And if the teeth are lost, the whole load will be transferred to the temporomandibular joint, and the stability of the TMJ depends on both anteriors and posteriors. And stability of dental arch, even the stability of dental arch is also depending on both the anteriors and posterior teeth. Now let us see what is the natural history of dentition in high risk patient, high risk. Now, initially, you will have a situation of healthy dentition, and later on, when you see some teeth missing, so they come under minor changes. And finally, when you see major teeth missing, like in both the arches, when posteriors are missing, we consider it as major changes. And finally, that results to impaired occlusion. And once all the teeth are lost, it is total edentullousness. And what happens when the patient becomes totally edentulous? The whole load, the masticatory load, is transferred to the bone, and there is loss of alveolar bone. So that is the last one, that is the loss of alveolar bone. Now let us see the sequelae of tooth loss. So it starts with once if you see there is loss of teeth or a single tooth, the adjacent teeth tend to migrate into this edentulous area. So there will be some kind of malocclusion happening on one side, and patient tends to start chewing only on one side. So there is unilateral chewing. And on the other side, where there was tooth loss and there was migration of the adjacent teeth, there is alveolar bone loss. And with the alveolar bone loss and migration, there is an occlusal interference, and there is loss of proximal contact and overloading of anteriors. So if this happens when you have no teeth in the posterior sides, you have more loading which is happening on the anteriors, and once this happens, there is loss of vertical dimension. So the lower facial height, particularly from the tip of the nose to the tip of the chin, which is called as the lower facial height, there is loss of vertical dimension. And when the teeth are lost, the teeth, as I told you before, the teeth act as the teeth act as if they are protecting the TMJ. They are the stress breakers of the TMJ. And once these teeth are lost, the whole loads are transferred to the TMJ, and this results in temporomandibular joint disorders. Now coming to the patterns in partial edentulosum. So there is a famous classification which is called as Eichner's classification, and we have another classification like complicated and uncomplicated, and we have shortened dental arch and tooth bound space. Now all boys, concentrate very carefully. Let us see this classification. Now here the classification is divided into three classes: class A, class B, and class C. And in class A, there are class A1, class A2, and class A3. Now, just observe this very carefully. Now, here in this photograph, we have the whole arches, both the maxillary and mandibular arches, with full dentition, right? All the teeth are present. And if you observe carefully, we have, these are the occluding units. We have 1, 2, 3, and we have, this is the fourth one, which is 1, 2, and 3, 4 occluding units. Now coming to A2, if you observe here, these are intact, but here we have one unit which is slightly lost, right? Yeah, loose. Okay, right? And when you come to A3, just observe A3. In A3, there are two dental arches with interdental missing teeth. So you have these units. You have these units which are having missing teeth on both sides, right? So this is what is all about class A. Now coming to class B. Now observe carefully, boys. Here in class B, again class B is further divided into B1, B2, B3, and B4. So here in B1, intermaxillary contacts in 3 occlusal supporting zones. So if you observe this photograph carefully, the dark zones are these where you have occluding surfaces, which are, these are the occluding surfaces. So you have 3 occlusal supporting zones, whereas in B2 you have only 2 occlusal supporting zones. This is the one, and you have one more like this, right? And in B3 you have only 1 occlusal supporting zone. There is only one which is supporting there, whereas if you observe here in this area, there are no occlusal supporting zones. That means though there is a molar here, this molar is not supported below by another molar. Here you have one molar, but there is no opposing molar. Here you have a premolar, but you don't have another opposing premolar. Here you have a premolar in the lower arch, but you don't have a premolar on the opposing arch. So hardly in B3 you have only one supporting zone. And what is B4? B4 is a condition where intermaxillary contact apart from occlusal supporting zones. So all you have the contacts is only in the anterior region. So you have only contacts with the anterior region. At this position, the patient tends to chew food from the anterior teeth. He won't chew the food because there are no occluding surfaces there in the posterior teeth. So patient tends to chew the food in the anterior area. Now coming to the C side, class C. What happens in the class C? So in the class C, we have two dental arches with residual dentition. So if you observe here, see this dentition is just, it's a dentition. The teeth are there in the patient's mouth, but they are just useless. They are not helping in masticatory function at all, right? And in the class C2, you have a situation where you have teeth on one arch and no teeth on the other arch. And in class C3, you have two edentulous arches. Both the edentulous arches are present. You have both edentulous arches, completely edentulous mouth. So this is what is about Eichner's classification. And there is a simple classification which is complicated and uncomplicated. So if you observe here carefully, so if you observe here, this basically is a uncomplicated tooth bound space. You have teeth on both sides, right? And there is an edentulous area between these two teeth. And there is no supra-eruption of the maxillary molar as well as the premolar there. So this is a simple, uncomplicated tooth bound zone which can be easily rehabilitated. But you have a situation wherein you have a complicated zone wherein you have a supra-eruption of these two teeth, and this zone is slightly compromised because there is migration of the lower anteriors towards this edentulous area, and even the molar is slightly tilted towards the edentulous area. So this is a complicated tooth bound space showing migration of remaining natural teeth, right? And there is one more classification which is uncomplicated shortened dental arch and a complicated shortened dental arch. What is a shortened dental arch? What is a shortened dental arch? A shortened dental arch is something you have teeth which are slightly, maybe the posteriors are lost. When the posterior are lost, it's called as a shortened dental arch, right? So here, if you observe this photograph carefully, concentrate on the anterior teeth. In the anterior teeth, there are no spaces. But if you observe the second photograph here, concentrate on the anteriors, you have spacing. You have spacing in the anterior teeth. There is migration of the anterior teeth slightly distally to occupy the free space which is available posterior to the remaining natural teeth. So this is what is called as a complicated shortened dental arch. So this is the difference between an uncomplicated shortened dental arch and a complicated shortened dental arch, right? How do we treat it? Yes. Coming to this question, how do we treat it? See, in this situation, when we are trying to treat it, first of all, we have to see the occlusal plane. We have to correct the occlusal plane. So by chance, if the occlusal plane is proper, you can start rehabilitating the rest of the teeth. So here, I think in this situation, the occlusal plane is perfectly fine. You should check for curve of Spee. You should check for curve of Monson. So if the occlusion, if there is no supra-eruption, if there is no huge amounts of migrations, then you can start rehabilitating these cases with removable partial denture or implants in this situation. But in the complicated shortened dental arch, sometimes you need to correct the occlusion first. Later on, you can rehabilitate the edentulous areas. Clear? Yes. Now, what are the consequences of tooth loss? What happens when there is tooth loss? Okay. So with the loss of teeth, the residual ridge no longer benefits from functional stimulus it once experienced. So loss of ridge volume in both height and width can be expected. And in general, bone loss is greater in the mandible than in the maxilla and more pronounced posteriorly than anteriorly. And it produces a broader mandibular arch while constricting a maxillary arch. So here, let us try to understand these points. Now, if you observe the maxilla, suppose you have your maxilla like this, right? Now, what is the resorption pattern? When the teeth are lost, the resorption pattern is in this fashion. It is upwards and inwards. So the maxilla becomes smaller and smaller and smaller, right? And coming to your mandibular arch, what happens is in the mandibular arch, the resorption pattern is downwards and outwards, right? So it is downwards and outwards like this, like this. Okay. So what happens here? Because of this, the ridge becomes broader and broader, right? So in the due course of time, your maxilla becomes smaller and smaller and your mandibular arch becomes broader and broader. So arranging teeth is a, yes, reverse. Yes, reverse. So arranging teeth on the crest of the ridge becomes a huge problem in such kind of situations, right? And these anatomic changes can present challenges to fabrication of prostheses, including implant-supported prostheses and removable partial dentures. And associated with this loss of bone is an accompanying alteration in the oral mucosa also. Even the mucosa, the oral mucosa is of three types. It is orthokeratinized, parakeratinized, and non-keratinized. So the areas which are orthokeratinized, like the hard palate, the mucosa which is there on the residual alveolar ridge, all these areas you can find orthokeratinized tissue. But in the due course of time, because of heavy masticatory loads, this orthokeratinized layer becomes a non-keratinized layer, which is more readily traumatized, which is easily susceptible to trauma. Now let us see what are these physiological changes. Physiological changes means what is the mechanism which is happening in the periodontal ligament. Now, chewing studies have shown that the oral sensory feedback that guides movements of the mandible in chewing comes from a variety of sources. So whenever a patient chews food, so he enjoys that food. Why he enjoys that food? Because there is a mechanism which is happening from the periodontal mechanoreceptors. These mechanoreceptors, they send signals to the brain that, wow, I'm eating a solid food, I'm enjoying the food. And additional inputs are also given by the gingiva, the periosteum, and the bone, and the temporomandibular joint. So all these components, the periodontal mechanoreceptors, the gingival mucosa, the periosteum, bone, temporomandibular joint, all these, what they do, they have a mechanism through which they send signals to the brain that I'm enjoying the food, right? And when the teeth are lost, what happens when the teeth are lost? When the teeth are lost, everything, all the periodontal mechanoreceptors are not there, right? So the chewing as a learned behavior has a basic pattern of movement that is generated from within the central nervous system. In typical function, this patterned movement is moderated on the basis of food and task needs or by oral sensory inputs from various sources. So when this finely tuned contribution from tooth periodontal mechanoreceptors, the resulting peripheral receptor influence is less precise in muscular guidance. So when you don't have teeth, when the patient doesn't have teeth, and when you are fabricating a complete denture and placing it in the patient's mouth, he won't have the exact chewing strokes what he had with the natural dentition. So what all he does is only the muscular function, the muscular guidance helps him to chew food. So he won't have periodontal mechanoreceptors, he won't have signals from gingiva, signals from temporomandibular joint, uh, there won't be any signals from oral musculature. So all these are not there when we give dentures to the patient. And the next thing is the aesthetic impact of tooth loss can be highly significant and may be more of concern to a patient than loss of function. So here, when a patient loses the front teeth, it becomes a social stigma. He cannot move in a society. She will have a lot of problems. You can see some patients, particularly in the clinics, when they come, when they smile, they put their hand in front of their mouths so that they conceal their mouth. They cannot show their mouth. So all these are social stigmas. They will have these problems, and once you rehabilitate them, you are bringing them back to life. So with loss of teeth and diminishing residual ridge, facial features can change as the result of altered lip support and or reduced facial height, which is caused by reduction in occlusal vertical dimension. So when you restore all these things, they are back to normal position. And functional restoration with prosthesis. In my experience, there are different levels of patients. When you have two cases, most of these two cases are almost identical. You have some missing teeth, and when you fabricate dentures, you can observe that the same dentures which were fabricated by you, one patient will accept it very well, whereas the other patient may not accept it. So the level at which a patient finds function to be unacceptable, it varies among individuals. So this variability increases with accelerating tooth loss. So these variables may be confusing to you, and you may perceive that you have provided prosthesis of equal quality. You may think that I've given the best quality of prosthesis to both the patients, but some patients, they accept it very fast, some patients, they don't accept it, and it all depends on the patient's report of success. So an understanding of these variations among individuals with a full complement of teeth and those with prosthesis can help clinicians formulate realistic treatment goals that can be communicated to the patient. Now, what are the effects of tooth loss? The following are the effects of tooth loss. You can see bone loss, you can see shifting of teeth, you can see bite irregularities, you can see difficulty in chewing, facial aesthetics, and speech issues. I told you, when there is no positive stimulus, because when there are no teeth, there is no positive stimulus to the bone, so the bone starts resorbing. So there is residual alveolar resorption, residual alveolar ridge resorption, which is happening, and this is almost related to something called as disused atrophy. Whenever you don't use something, it gets atrophied in the due course of time, right? So this is what happens, and there is bone loss when there is loss of teeth. There are no periodontal mechanoreceptors to give the positive stimulus. And when you place dental implants include screws that fuse with the bone to provide maximum strength and support. So this process, the implant not only supports the jawbone, it also supports the visible crown. So basically, a dental implant can provide this positive stimulus, which was provided by the periodontal mechanoreceptors. So this can slightly retard the bone resorption. And you can see the shifting of teeth. You can see here very clearly there is supra-eruption of these two teeth. There is migration of these two teeth into the edentulous area. And apart from this, in the due course of time, you can see all the teeth migrating into these zones, So all these are problems which they face because of shifting teeth. And once the teeth are shifted, when they are migrated, you will have bite irregularities. So bite irregularities are more commonly seen because of missing teeth. And you can see malocclusion here. This is the correct occlusion, and you can see the malocclusion. In correct occlusion or normal occlusion, you can find cusp to fossa relationship, whereas in this area you can observe a cusp to cusp relation. You can see gaps between the teeth, whereas here in the normal occlusion you can see a cusp to fossa relationship. So, and here also you can observe very clearly an improper bite can lead to a variety of problems, including things like headache, muscle pain, unnatural wearing of the teeth, tooth loss, sensitivity, and even temporomandibular joint disorders. And orthodontics can help to correct malocclusion, but it can be an expensive and lengthy treatment process. So this requires a lot of orthodontic treatments also. So just in case if a tooth is lost, it's always better to get it replaced instead of spending expensively for orthodontic treatment. And if the anterior teeth are lost, the patients will have difficulty in chewing. So particularly if the teeth, the centrals or the laterals or the canines are lost, there will be difficulty in chewing and biting the objects. Whereas if the molars, premolars are lost, it will be difficult in grinding the teeth. So missing molars therefore affect the manner in which patients choose everything. So any failure to chew adequately can impact digestion. So missing molars will have a serious effect on digestion, resulting in problems like acid reflux. So this sort of nonsense is completely avoidable by replacing missing teeth. And the next aspect is facial aesthetics. So as age advances, there are changes in the face, and with the loss of teeth, these changes are much more pronounced. And the patients with removable dentures, when they take them out, a sense of the effects of missing teeth on appearance are visible. Particularly when you see old patients who are wearing complete dentures, once they remove their complete dentures, you can see a collapsed bite and there is a decrease in the lower facial height. And finally, you will have speech issues also, particularly the centrals, laterals, and canines. Most of the times, certain words require centrals, the anterior teeth, with which the tongue moves and touches the palate sometimes, and it touches the lingual aspects of upper anteriors. So when these teeth are lost, patient will have speech issues. And coming to the last thing, what are the 6 phases of partial denture service? They are: first, you need to educate the patient. Then once the education of the patient is done, TMJ spasm, TMJ spasm. Yeah, I would say TMJ disorders. Yeah, temporomandibular joint disorders, right? It's called temporomandibular joint disorders. Generally, you get them in yeah, yeah, temporomandibular joint disorders. Yes, yes. Right now, what are the 6 phases of partial denture service? Now, what the 6 phases of partial denture service are: first, you need to educate the patient and follow the proper protocol of taking case history. You diagnose the case, plan some treatment, then you go with the design. Then, based on your treatment plan, you need to sequentially start your treatment plan. You start with the extraction of hopeless teeth, then you go for thorough oral prophylaxis with scaling and root planing. Then, if any mouth preparations are required, you send them for endo restorations, endo, then FPD, crowns, then later on bridges if bridges are required. Then finally, you start with your removable partial denture. And by chance, if you see a tooth supported RPD, it is a bit easier when compared to tooth and tissue supported RPD. So when you have a distal extension base, you need to look for the support for your distal extension base. And the next thing is establishment and verification of occlusal relationships and tooth arrangements. Once you record the distal extension bases, you need to do proper jaw relations and you start arranging the teeth. And once your dentures are ready, you place them. This is what is called as initial placement procedures. And once the dentures are inserted, you periodically you do a regular checkup of the dentures. After 24 hours, you call the patient. Then again, after 1 week, you call the patient. Then again, after 1 month, you call the patient back again. And every 3 months, you can call the patient and you can regularly check up. And maybe after 5 years, you might require a reline of the old dentures. And maybe after 7 to 8 years, you might go for a new set of dentures. So it's not compulsory that once you deliver the dentures, you are done with the patient. Once a complete denture or a removable partial denture comes to you, it's a lifelong procedure. So patient education, it should start with written consent. You need to take proper consent of the patient that I'm going to do a treatment for you so that it improves your all forms like aesthetics, function, and the loads will be uniformly distributed. So you need to explain everything to the patient, and most of the patients, they don't know anything. It is your duty to explain them, convince them for the treatment. And once that is done, you do the diagnosis. You check for caries, you check for existing restorations, you check for periodontal conditions, you check for response of the teeth and vitality of remaining teeth. Then after that, you check for occlusal planes. If the occlusal plane is compromised, you need to go for mouth preparations. And there are two types of edentulous areas. One is tooth supported area, one is tooth and tissue supported area. So here, this area requires a denture which is called as a tooth supported area. And you have one more area which is called as tooth and tissue supported area. So in these two areas, we need to have certain different impression procedures. It's always easy when you have a tooth bounded saddle when compared to a tooth and tissue bounded saddle. And when you, okay, class 1 and 2. Yeah, both class 1 and class 2 are, yes, distal extension bases. Both class 1 and class 2 are distal extension bases. And this one, it's a tooth bounded saddle, is a class 3 and class 4 situation. So it's always easy to treat a tooth bounded saddle because most of the times the teeth will take they will provide the vertical support from in the form of rests. Whereas in a tooth and tissue supported area, the support is derived from the edentulous area, that's the distal extension basal seat. Now, once that is done, you establish your bite rims or your record blocks. You fabricate your record blocks and you start with your jaw relations and your teeth arrangement. And once that is done, You fabricate your dentures. The occlusal harmony must be ensured before the patient is given possession of the dentures. Make sure that you have a proper occlusal plane, and once everything is fine, the dentures can be inserted into the patient's mouth. And it is your responsibility to educate the patient about the post-insertion. You need to clearly explain all the post-delivery instructions. And after that, you need to regularly go for a periodic recall. So these examinations must monitor the condition of the oral tissue, the response to tooth restorations, the prosthesis, the patient's acceptance, and the patient's commitment to maintain oral hygiene. So all these are there in the periodic recall. And finally, the current practice in the management of partial tooth loss involves consideration of various types of prosthesis, and each type of prosthesis requires the use of various remaining teeth, implants, and or tissues, and consequently demands appropriate application of knowledge and critical thinking to ensure the best possible outcomes given patient needs and desires. So you should have a proper knowledge of what type of treatment you're supposed to do for the patient when there are missing teeth, whether to go for implants, whether to go for an FPD, or whether to go for an RPD. And you should always keep in mind about the patient's desires, patient's needs, and the patient's expectations. And these are my references. You have an excellent Saudi digital library. So here I've collected many articles on this. So you can have a look. Just cut and paste these in the Saudi digital library. You will get the whole article, and that will help you in further reading if you want to. Thank you very much. Thank you, boys. That's good. 25 students are there. Excellent. Thank you very much. I'm stopping the recording.